Well, good morning to everyone. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. We'll get started with just a couple reminders and some logistics, and then introductions for today's speaker. Next week, be sure to join us. We will be hearing a talk about rate versus rhythm control for AFib, given by Dr. Rajabali. Stay tuned to see if that will be back in person, hopefully so, next week at Providence St. Vincent Southern Auditorium at 8 a.m. Either way, it will also be available virtually on Teams Live. And then Dr. Schaefer's Thieves Market has been rescheduled for in-person at St. Vincent on Tuesday, March 11th. So definitely look forward to seeing you in person for that engaging and fun and informative presentation. So Grand Rounds is a joint effort between St. Vincent and Providence, Portland. We often meet in person Tuesdays at 8 a.m. at St. Vincent's and sometimes at noon at Providence, Portland. You can always find out where we'll be from the weekly invite, and Grand Rounds is always available to watch virtually on Teams Live. You can also earn CME credit through any of those formats, live in the room, virtual live, or by watching a recording of the event, and that recording is the same link as the Grand Rounds invite each week. I will be keeping an eye on the Q&A during today's presentation, so please go ahead and post any comments or any questions you have, and I will mostly hold those until the end as time permits. And now we are very excited to introduce today's speaker and appreciate her willingness to pivot and present virtually today. We are joined by Dr. Carolyn McCulley, a practicing rheumatologist at the Providence Portland Arthritis Center. She attended medical school at Oregon Health and Science University and then did her internal medicine residency at our own Providence Portland, followed by rheumatology fellowship back at OHSU. Dr. McCulley worked as a rheumatologist in Bend, Oregon before returning to Portland in 2021. We're delighted to have her back. She's regarded for her teaching and coordinates the Providence Portland rheumatology curriculum and clinical experience for its residents. Dr. McCulley, thank you so much for joining us today.
Thank you so much for having me. This really is an honor. And I was just reminiscing that I've come full circle from sitting in the audience in the real life Grand Rounds to now presenting virtually. Hopefully that will return in person soon. Today, I'm really excited to discuss a topic that I think touches every specialty, every subspecialty, inpatient, outpatient, and that is the fever of unknown origin. This is a sort of a fun topic that we as rheumatologists often get to interact with our subspecialty colleagues and put our brains together for some of these tricky cases. So I'm going to be giving you my rheumatologist perspective of the FUO, fever of unknown origin. My disclosure, it's not relevant today. The objectives of today's talk starts with what is an FUO? Let's all be on the same page about what we're talking about. Then I will review an approach to evaluating the FUO, which sometimes these cases can be overwhelming. So I think at any stage of practice, it's helpful to review this. Then the fun part, I'll be reviewing 8 cases. These are real life cases that I was involved in and will be an exploration of the rheumatologic causes of FUO. And then finish up with some final thoughts some final thoughts. I really was tempted to say, I know it when I see it when considering what is an FUO, but I think we should probably be a bit more specific. This was first described in the early 1900s as a long fever lasting more than 2 weeks. 50 or so years later, a specific temperature at 38.3 Celsius, and duration for 3 weeks. And then they added in, well, we need to add in some inpatient investigations. And then this further evolved over the following 20 years or so to say, well, we can also count outpatient visits because now a lot of medicine is done on the outpatient setting. Ultimately, there's no consensus. Reviewing many studies and meta-analyses, there's no true consensus. So I think highlighting the core features is the most helpful place to start. And this was done in this really nice article in the New England Journal of Medicine a few years ago. And the core features are, 1, there's no identifiable cause of the fever. After completing reasonable investigations, which we will review, and the fever has persisted long enough to rule out self-limited fevers. So a modern definition might be unexplained fever despite high quality diagnostic workup after a reasonable amount of time has passed to rule out self-limiting fevers. And as we'll see in the coming cases, that reasonable amount of time and diagnostic workup, all of that, it can be fluid in our modern medicine. The FUO, fever of unknown origin, has evolved over time. The overall perception is that autoimmune and autoinflammatory causes are the most common causes, more so than infections. However, this really does vary by country, the type of hospital, from a tertiary setting to a rural setting, and then the patient population that's served there as well. Infections do remain the leading cause of FUO worldwide, and these are associated with lower income regions. Still, in my constantly being humbled in my job, over half of cases of FUO remain undiagnosed, and this is more common in the higher income regions. There are multiple subcategories of the FUO. Today, we're just going to be talking about the classic FUO and not diving into those related to the hospital setting, immune deficiency, transplant recipients, etc. That's a whole other ballgame. So going more into my world, the thought is that about 22 to 32% of FUO cases ultimately are due to an autoimmune etiology. I wanted to just clarify some verbiage here. The autoinflammatory, that indicates a disorder of innate immunity, whereas an autoimmune disorder indicates a disorder of adaptive immunity. In reality, most of the diseases that we see and treat are a mix of both. But just to be clear, I am using the term autoimmune, and that often sort of incorporates the autoinflammatory diseases as well, just for today. Another challenge in my world is that many of the diagnoses are clinical and based on certain criteria, and we do not have a gold standard diagnosis for many autoimmune diseases that we see and treat yet. So this is something that's important to remember. And then finally, there are no specific clues that indicate, this must be a rheumatologic cause to this FUO. But in the literature, the autoimmune etiologies tend to be in older patients over 65, those with multi-system involvement, including inflammatory arthritis, skin rashes, cutaneous involvement, lymphadenopathy, and the longer duration of fever makes it more likely that it will be an autoimmune diagnosis. So our very basic framework starts with step one, ruling out infection always. Then we need to rule out malignancy. Then considering common rheumatologic diseases, and then we get to look for the zebras. To be a bit more specific, again from this article from 3 years ago, we start with the minimal initial evaluation. And this is the good history and physical that we all learn about in medical school. History definitely needs to include new medications, travel, any exposures to different dietary intake or animals, and then a really thorough exam starting from the top of the head down to the toes, and including skin, joints, and lymph nodes. The next step is to confirm a fever and then withhold any antibiotics if the patient is clinically stable and not neutropenic, and then determine whether or not they need to be hospitalized. At this point, the next minimal step in evaluation that's recommended is a basic lab, CBC, CMP, blood cultures, HIV, echocardiogram, a pan scan, CT chest, abdomen, and pelvis. And then if there are clues as to other regions that may be involved, scanning those regions as well. And then considering discontinuing any new or potentially offending medications. After that evaluation, if there's still not a diagnosis, the next step is to check for more uncommon infections such as zoonotic or tick-borne illnesses, endemic mycoses, viral hepatitis, tuberculosis. And then it's only at this point that it's recommended to start considering an autoimmune diagnosis and testing for rheumatologic or thyroid disorders. Also, tissue is the issue. So if there's something to biopsy, if there's a rash, there's a painful temporal artery, there's a lymph node, anything that we can get some tissue for more objective information, this would be the time to biopsy it. So at this point, there's either a diagnosis is made and we treat accordingly, or potentially in high-risk patients, considering empiric treatment for an infection. Or the other end is there's no diagnosis. This is often the time that rheumatology is consulted. The hemonc and ID both say, well, not cancer, not infection, let's get rheum involved, and then we're consulted. And at this point, we reevaluate the clinical status and history, always need to consider a factitious fever. And then a next step that's recommended is the FDG PET CT scan, if this has not already been done, and I'll mention a little bit more on the next slide about this imaging study. It's also important to consider a metagenomic testing for infections. And there are times where there seems to be an inflammatory or autoimmune problem without a definite diagnosis. And if there's no contraindication, this sometimes is a time where we will recommend starting empiric anti-inflammatory therapy, typically with steroids or prednisone. And then we get to the humbling knowledge that about half of patients with a fever of unknown origin will not have a definitive diagnosis yet, and so keeping that in mind as well. Just briefly, the FDG PET CT scan is a scan more commonly used in the oncology world where a radioactive substance, the FDG, is injected into the patient's bloodstream and then accumulates in areas of high glucose demand, such as tumors. It has a high sensitivity for identifying areas of inflammation. The specificity, not quite as good, but ultimately the diagnostic yield in the setting of the FUO is about 50%, which is at least 30% greater than the conventional CT scan. This does perform better in patients with infections and malignancy. And I think it's important to know that actually a negative scan is really helpful in that it indicates a high likelihood of spontaneous remission of fevers. We all like pictures, so I've included some images of FDG PET CT scan in patients with in a patient with large vessel vasculitis, and you can just see how beautifully the aorta lights up, the femoral arteries, and this is a really nice demonstration of its use in the FUO and autoimmune world. This is beyond my expertise, but the next generation sequencing is a test that is used to look to further look for more infections. I briefly spent a few minutes on the phone last night. We do have this capability in our lab through the genomics department, and they apparently do this quite often. So it is something that we have access to. All right, before we jump into the cases, I just have a few words of warning. First of all, some diagnostic clues may be a bit misleading. Many are helpful and do help us determine diagnosis, but studies suggest that 48 to 80% of clues can be misleading. So I call this the red herring. Many FUO syndromes are due to uncommon manifestations of common conditions. And then also I think it's really important for us to consider the pretest probability of a diagnosis before ordering a test. As we know, the more tests that we order, the more likely we're going to get a false positive. So we need to know how to deal with any, or how to interpret any result. Okay, now the fun part. We are going to dive into some cases. Our first patient is a 78-year-old male retired fireman. He's had prostate cancer remotely and hypertension. He presents in the outpatient world with 6 weeks of low-grade fevers, 100 to 101, he says, full body pain and stiffness. And he says, it feels like I'm dying. And he actually started getting his things in order so his family wouldn't have to deal with too much after his impending death was what he was concerned about. He had daily fevers up to 101. He'd unintentionally lost over 20 pounds. He denied any headaches, vision changes, jaw pain, chest pain, short of breath. He's up to date on all his malignancy screening. He lives on a property in Newburgh, but no known animal or diet exposures, no recent travel. You can see his vitals here. And really the most notable thing on exam was that he required assistance from his petite wife to stand up from the chair and get up onto the exam table, and also really had painful and limited range of motion in his bilateral shoulders. Data was obtained, and you can see here is CBC with evidence of inflammation with a leukocytosis. He's got a mild anemia, thrombocytosis. His inflammatory markers are elevated, ESR is 91, CRP 17, and negative rheumatoid serologies. And then his chem panel is overall unremarkable. This patient, 78-year-old male, coming in with abrupt onset bilateral proximal upper and lower extremity pain and stiffness with daily low-grade fevers, elevated inflammatory markers, has near the top of the differential is polymyalgia rheumatica, PMR. Part of this diagnosis is how the patient responds to prednisone. So he was given 15 milligrams of prednisone, and the following week came back singing praises. Oh my gosh, I'm going to survive this. I feel like $1,000,000. I would highlight that this is a low dose of prednisone. We're all going to feel pretty excellent if we are given 60 milligrams of prednisone, but the low dose really is a sensitive part of diagnosing polymyalgia rheumatica, PMR. So this is our first autoimmune FUO, is the PMR, which literature suggests is about 7% of autoimmune FUO cases, and close to 20% of patients with PMR will have a fever. PMR is a fairly common entity in the world, and everyone will see this condition both on the inpatient and outpatient setting. The term polymyalgia is actually a misnomer. This does not involve muscles, whereas a myositis does involve muscles. This is actually more of an inflammatory arthritis, bursitis, and enthesitis. So the entheses is where the tendon inserts into the bone so that the entheses become inflamed. This is a classic clinical diagnosis. Patients, they are fine one day and then they wake up the next and they cannot get out of bed. They're so stiff, they're so achy in their proximal upper and lower extremities bilaterally. This they are not truly weak. So if you kind of torture them and then you get a good strength exam, they are not weak, but they're very painful. They might say they're weak because they don't want to move their extremities, but they are not weak. This only occurs in patients after the age of 50, and most will have elevated inflammatory markers. Part of this diagnosis is that 100% response to low dose of prednisone, meaning really 20 milligrams or lower. Also, it's important to remember this diagnosis is associated with the onset of rheumatoid arthritis, especially in the elderly population, and giant cell arteritis. Our next case is a 63-year-old female coming to the emergency room with 2 weeks of daily fevers up to 103. She's lost 17 pounds, and over the last week or so, she's had stuttering episodes of double vision. She's also having some daily headaches, and this feels different from her more typical tension headaches, and she's experiencing some right arm pain. She says she's stiff and achy all over and overall doesn't feel good. She did urgently see her ophthalmologist last week due to the vision changes and had an unremarkable exam. In the emergency room, she's febrile, as you can see here, and notable that her right upper extremity has a much lower blood pressure, 96/50, compared to the left upper extremity. She appears tired. She's needs help getting onto the exam table, and on exam, it's notable that she also has some tenderness along her temples and a diminished right brachial pulse. Labs are obtained in the emergency room, and she's CBC notable for inflammation. And then in her additional lab, she has elevated inflammatory markers, negative rheumatoid serologies. She has a positive ANA because that was obtained because it's on the autoimmune panel. And then she was admitted to the hospital, and given high concern for giant cell arteritis, she underwent a temporal artery biopsy, which showed some classic findings of focal and segmental transmural inflammation of the arterial wall. There are a couple of multinucleated giant cells as well, and some mixed inflammatory cells. This is a pretty classic case of giant cell arteritis, and I think it's important to know about this. This diagnosis or patients with this diagnosis will present both on the outpatient and inpatient setting, and accounts for about 11% of autoimmune FUO cases. 25 to 50% of patients with this condition will have a fever at the onset as well. Giant cell arteritis is the most common large vessel vasculitis that we see. And the diagnosis starts with a clinical suspicion, and then we do have some more specific modalities of diagnosis. The classic symptoms are going to be an abrupt onset temporal headache, and that is due to vasculitis of the temporal artery causing relative ischemia, vision changes, which is due to vasculitis of the posterior ciliary artery, which then causes ischemia of the optic nerve, which actually more commonly causes diplopia, blurred vision. In med school, we learn about amaurosis fugax, which in reality, I've had one patient have this, so that's a less common vision change in this diagnosis. Jaw claudication is actually the most specific clinical symptom of giant cell arteritis, and I don't know if you can see my arrow here, and that is because there's ischemia of this artery that serves the masseter muscle, and so you get angina of the muscle there, and so patients report pain or fatigue with chewing. All patients with vasculitis will have elevated inflammatory markers, and this is associated with polymyalgia rheumatica. In the United States, the gold standard diagnosis still is a temporal artery biopsy, demonstrating those classic findings that we saw on the previous slide. In Europe, the temporal artery ultrasound is actually the gold standard diagnosis now, and we are beginning to incorporate it more into our practice here in the United States. Our institution does do temporal artery ultrasound and is able to get patients in quickly. And then this is read by vascular surgery or sometimes cardiology. And there's a classic halo sign on the ultrasound. A critical point to note here is that even 2 days of prednisone will significantly affect the ultrasound. And so this, if a patient has been on prednisone for 2 days, there's really no use because it will look normal. That you will not see the findings of the vasculitis. The other is that this is also very much an operator and reader dependent diagnosis on the imaging, and so there has been some hesitancy until we all become more familiar with this modality. I've also mentioned CTA as used for imaging, and that's because there are quite a lot of folks who have extracranial involvement, and so it is standard of care now for patients with a suspected diagnosis of giant cell arteritis to have that CTA imaging of the chest, abdomen, and pelvis to evaluate for other areas of vasculitis, which significantly increases the risk of aneurysms in the future. Our patient had a normal ophthalmologic exam, but I thought these were some nice pictures as well. This one demonstrates optic disc edema, which is what an ophthalmologist can see when there is optic nerve ischemia. This is more common to see a little bit later into the disease, and that where we can have a falsely negative exam is if an ophthalmologic exam is done earlier in the disease course. And then there are these flame shaped hemorrhages. And then here I've just shown these kind of beautiful biopsies of the temporal artery. The first is this control where we see a nice patent opening to the artery, whereas this classic giant cell arteritis, temporal artery biopsy demonstrates that significant narrowing of the vessel. We have some giant cell infiltrate into the vessel wall, and as well as that thickening, which leads to that end organ ischemia. Our third case is a 21-year-old female coming to the emergency room with 9 days of fevers up to 103. She's reported a sore throat. She's got a headache, abdominal cramping. She went to the urgent care a couple of days after symptoms started and had negative COVID and flu tests. She was a little tachycardic and febrile there, but given supportive care due to concern for a viral illness. A couple of days later, she went to the urgent care again due to persistent fevers. You can see here she had a more extensive infectious workup, which was negative. She had a highly elevated CRP, and procalcitonin was fairly unremarkable. She was seen by her PCP thereafter, who thought, well, maybe this is a UTI. You've got some abdominal cramping and a fever, and gave her amoxicillin, which did not help her symptoms. Over the following 3 days prior to coming to the emergency room, she described significant dysphagia and developed a rash that moved around on her body, and then she developed pain and swelling in her fingers, and her family brought her to the emergency room. On exam, she's febrile, she's tachycardic to the 130s. Overall, she just appears sick. She's miserable. She's got some tender cervical lymphadenopathy. She does not have any oral ulcers. She's tachycardic on exam with a little murmur, some crackles in her lungs. Her abdomen is diffusely tender, but no guarding or notable hepatosplenomegaly. On her skin, she's got a diffuse coalescing erythematous macular, mildly papular rash, which moved from one arm to the next to her leg over the course of the day. And on exam, she really has tenderness and synovitis of most joints, the front of PAPs, MCPs, wrists, elbows, and her knees, ankles, and toes. And here you can see an example of the rash that she had and then the synovitis in her hands. Initial data demonstrates mild thrombocytopenia. She also has elevated LFTs, as noted here. She had a more broad infectious workup. At this point, infectious disease was involved, and you can see her overall negative, aside from the indeterminate quantiferon gold. And her troponin was highly elevated as well. She had a negative ANA, notably. Her inflammatory markers were highly elevated. Ferritin was over 6,000, and elevated LDH and triglycerides. Due to the description of significant pain in her throat, she had a CT scan of her neck, which showed some small area, air in her tonsil region, which was of unclear relevance. CT, chest, abdomen, pelvis was overall unremarkable. And due to the concern for possible myocarditis, she had a cardiac MRI, which did not show any myocarditis. This is a fairly classic case of adult onset Still's disease. And this is another really important diagnosis for us all to be aware of, and accounts for about 22% of all autoimmune FUO cases. All patients with adult onset Still's disease will have a fever. This is one of the major criteria in the diagnosis. The Yamaguchi criteria is how we base the diagnosis, and this patients need to have 5 features, 2 being major with fever, one of these inflammatory arthritis, this evanescent salmon pink maculopapular rash, which is non-pruritic, and that description there is really a buzz term for the boards as well for this diagnosis. And then folks often have leukocytosis. Minor criteria include a sore throat, lymphadenopathy or splenomegaly, liver dysfunction, and the negative ANA is part of that as well. Nowadays, I would also include highly elevated ferritin. Often these patients have a ferritin around 10,000, and then elevated inflammatory markers as well. These patients are often young and they can get very sick. We need to monitor for evolution into the macrophage activation syndrome, MAS, which is where folks have persistent fever, highly elevated ferritin, thrombocytopenia. They can have a low fibrinogen, AKI, pulmonary edema, and it is life-threatening, potentially life-threatening. All right, now we're all going to eat a piece of humble pie here with our next case. This is a 74-year-old Vietnamese male with thalassemia and hypertension coming to the emergency room with 3 weeks of fevers. In the last couple of days, he's felt nauseous and vomited anything that he's tried to take in. Over the past year, he's presented to the hospital and been admitted with a fever of unknown origin multiple times, over 5 admissions. And each time there's an associated other finding, including uveitis, colitis causing a small bowel obstruction. He's had periorbital edema, retropharyngeal edema, and ear swelling. His labs have been notable for various cytopenias, and he's lost about 30 pounds over the past year. A gastroenterology saw him, and by the time they scoped him, he had a normal EGD and colonoscopy. He's certainly been seen by hem-onc both on the inpatient and outpatient side, and had a pan scan CT chest, abdomen, pelvis, which showed some nonspecific adenopathy, but nothing else that was specific. And hem-onc recommended a bone marrow biopsy. He was seen by an ophthalmologist who diagnosed him with uveitis, and every hospitalization infectious disease has been involved, and they've said, nope, not an infection. On exam, he has a low-grade fever here. He appears tired and uncomfortable. He's got a tender and swollen right parotid gland and periorbital edema, as demonstrated in this picture. He's mildly tachycardic on exam, some scattered crackles in his lungs, abdomen mildly tender, but no guarding. On his skin, he's got an erythematous patches on his trunk and extremities, as demonstrated here. And he does not have any inflammatory arthritis on exam today. Data is notable for mild leukopenia and anemia. He also has an AKI. His urinalysis demonstrates some active urine sediment with elevated white blood cells, some blood, some protein. Serum inflammatory levels are highly elevated. His ferritin's elevated. His IgG4 is elevated. He's had negative INCA and ANA, cryoglobulins, rheumatoid factor, and the infectious workup has always been negative. SBEP showed some possible monoclonal immunoglobulin elevation of unclear relevance. He underwent a kidney biopsy in the last hospitalization that we saw him in, and that because of the AKI, which demonstrated some patchy interstitial inflammation with focal global glomerular sclerosis. He underwent a bone marrow biopsy, which demonstrated hypercellular with myeloid predominant trilineage hematopoiesis and mild myeloid megakaryocytic dysplasia. There were no blasts there. Polyclonal plasmacytosis. And then he had a genetic test done. This is the UBA1 gene, and it had a mutation. What could this be? This is VEXAS syndrome. I don't know how many of you have heard about this, but it should be on everyone's radar. VEXAS stands for vacuoles E1 ubiquitin activating enzyme X-linked autoinflammatory somatic. This is a really recently described or discovered diagnosis, which is an adult onset inflammatory disease due to this UBA1 genetic mutation, first described in 2020, not even 5 years ago, out of the NIH. The reason it's really unknown the percentage of FUO autoimmune cases which can be attributed to VEXAS syndrome, But I included this diagnosis because the genomic studies are pretty remarkable, demonstrating that about 1 in 5,000 men over 50 have this UBA1 genetic mutation. And in this initial cohort study, all of the patients with the genetic mutation had some or all features of VEXAS. So it's suspected that we have been missing this diagnosis, or treating other diseases, which we such as relapsing polychondritis as such, when it really was actually the VEXAS syndrome. 92% of patients with VEXAS have recurrent fevers, and about 64%, this is the presenting symptom. And this was one of the symptoms that the patient had every hospitalization, was this fever of unknown origin. Diagnosis, first of all, just knowing about it, and we should consider this primarily in middle-aged to older men. It is an acquired mutation, and then when there's multi-organ inflammation. So this includes anything from the skin, cartilage, lungs, heart, eye. Typically, they have a macrocytic anemia, and they do need a bone marrow biopsy, and vacuoles typically are present on the bone marrow biopsy. And then the ultimate test is this UBA1 genetic mutation, which is a blood test, and it's a send out to the OHSU Knight Cancer Institute in this area. And this OHSU is actually doing, they're studying VEXAS, and so they've been very helpful in evaluating some of our patients with this diagnosis. I like this image because it really just highlights that the autoinflammatory attack can be on really anything from head to toe, from the inflammatory eye disease with periorbital edema, which our patient had both, chondritis in the ear, down through the bone marrow, the abdomen, and the skin is often involved as well. I've included this picture here of a patient previously thought to have relapsing polychondritis, where there's inflammation of the cartilage, commonly in the ear or the nasal bridge. And now it is thought that many of these patients have VEXAS syndrome. Final slide on this case is just highlighting the myriad cutaneous manifestations, which can include, again, the chondritis. They can include neutrophilic dermatoses, such as Sweet syndrome, leukocytoclastic vasculitis, medium vessel vasculitis. It really can attack anything. Our next patient is a 28-year-old African-American female. She's 22 weeks pregnant and comes to the emergency room with fevers, shortness of breath, chest pain. She's feeling lightheaded, her joints hurt. She's had fevers every day at home for the last couple of weeks, which has improved with Tylenol, but then recurs. She notes she's feeling short of breath all the time. She has to rest when walking across a room, and describing pleuritic and positional chest pain. She's also got a rash on her legs, which is not itchy, and her legs are swollen. On exam, she's febrile, she's mildly tachycardic, she appears tired and somewhat anxious. She has some non-tender cervical adenopathy, dry mucous membranes. There is an oral ulcer on her soft palate of her mouth, which she was unaware of. She's mildly tachycardic, with a slight murmur, and has 2+ pitting edema of her lower extremities. She has diminished breath sounds in the bases of her lungs. She's pregnant, gravid uterus. She has these erythematous patches on her lower extremities, as noted on the image here. And she has tenderness and synovitis of many of her joints as well, in a symmetric polyarticular pattern. Data here demonstrates a pancytopenia in her CBC. Her chem panel is unremarkable overall. She has a high titer positive ANA at 1 to 1280, elevated double-stranded DNA, anti-Smith, SSA. She's got low complement levels, C3 and C4, and a touch of protein in her urine. She had an echocardiogram, which demonstrated a moderate pericardial effusion, but no tamponade, and due to concern for possible PE, she had a CTPA, which demonstrated pleural effusions, but no pulmonary embolus. And there was concern that she may have lymphoma, and so a lymph node was biopsied, which demonstrated some reactive follicular hyperplasia, but no malignancy. This is a fairly classic case of systemic lupus erythematosus. I've highlighted this patient in particular because African American patients and women have more severe disease, and also pregnancy is is a time of high risk for flares and initial diagnosis because there's um, a strong hormonal component to flaring of this disease. Um, it is thought that about 11% of autoimmune FUO cases are due to lupus, and that about 40% of patients with lupus will have a fever either at the disease onset or during flares. This is usually a clinical diagnosis. The serologies are important. Everyone with lupus has a positive ANA. It's a very sensitive test. This is not a specific test, so there are many people with a positive ANA who do not have lupus. More specific antibodies that are helpful in the diagnosis are the double-stranded DNA and anti-Smith antibodies, and then patients have hypocomplementemia during times of active disease. Patients can have cytopenias, serositis, including pleuritis, pericarditis, peritonitis, nephritis as well, glomerulonephritis. About half of patients with lupus will have renal involvement, and this is a biopsy tissue diagnosis. Likewise, the cutaneous skin involvement is a biopsy diagnosis. Inflammatory arthritis, but really the lupus can do anything, and it can involve the central nervous system, peripheral nervous system, and others. Our next case is a 68-year-old Hispanic male farm worker with hypertension coming to an outside emergency room with his primary complaint is not being able to breathe. He's had a dry cough for 6 weeks, was initially treated with azithromycin. He's still feeling short of breath and having a hard time working. He notes he's had fevers up to 102 at home with drenching night sweats and lost about 25 pounds. He, over the last several days, developed an erythematous rash on his lower extremities, and his legs became swollen as well. And he was transferred to Providence, Portland for a rheumatology consult and due to concern for possible critical care needs. On exam, he's has a low-grade temperature, vitals are overall stable. He appears tired. He's sitting in a dark room because his eyes are injected, as this demonstration here, and very sensitive to light. He also has some erythematous swelling in his gums, as noted here. His pulmonary exam is notable for some scattered crackles. He has erythematous palpable purpura on his lower extremities, and no inflammatory arthritis on exam. Data is notable for evidence of inflammation on his CBC, and his creatinine is highly elevated. His urinalysis demonstrates an active urinary sediment with blood, white blood cells. He also has some granular casts. A kidney biopsy is done and demonstrates focal and segmental necrotizing and crescentic glomerulonephritis without any complement deposition. He has a positive ANA and also positive c-ANCA and PR3 antibodies. A CT scan here demonstrates some hazy opacities in both of his lungs with some solid and cavitary nodules. This patient has granulomatosis with polyangiitis, GPA, which is one of the ANCA-associated vasculitides. Used to be called Wegener's, but Wegener was a Nazi, so we do not call it that anymore. It is thought that about 7% of autoimmune FUO cases are due to GPA, and over half of patients with GPA will have a fever during active disease. I think vasculitis in general is a bit of a black box for many practitioners outside of rheumatology. And so I like to kind of simplify this and think, well, gosh, when should vasculitis be on the differential? First of all, anytime there's multi-system inflammation or multi-system ischemia, vasculitis should be on your differential. Also, weird ischemia, meaning 27-year-old with an MI. That's weird. Maybe it's coronary artery disease, kind of the bread and butter, but maybe this is a vasculitis that we should be having a broad differential. Also, pulmonary renal syndrome we should include a small vessel vasculitis on the differential. And then what we're talking about today, any systemic illness or FUO, this can be a consideration as well. Diagnosis is based, first we make a clinical suspicion. We have clinical suspicion based on that, typically multi-organ inflammation or small vessel vasculitis. And then tissue is the issue, so we want to ideally biopsy to make a diagnosis if possible. GPA often involves the sinuses, and the sinus biopsies are harder to interpret and can lead to false negatives or false positives. So ideally, if there's a kidney to biopsy or the lungs, that would be ideal. And then nowadays, serologies can take the place of a biopsy if there's no appropriate tissue to biopsy. And this is the ANCA, MPO, and PR3 serologies. Our patient, if you recall, had the injected eyes, and uveitis is actually one of the fairly common manifestations of GPA. And then also that strawberry gum appearance is one of the mucocutaneous manifestations. Our next to last case is a 39-year-old female, 7 months postpartum, coming to her PCP due to 5.5 months of polyarticular inflammatory arthritis. She has been unable to lift her baby due to her swollen and painful hands. She's had disrupted sleep, not just from the baby, but also from the pain. She's had low-grade fevers at home and lost about 30 pounds. She feels short of breath and tired, and notes that her left eye has felt irritated and sensitive to the light. Vitals are all normal on exam. She's otherwise, exam is most notable for the skin. She's got some scaling rashes on her elbows. And then on musculoskeletal exam, she has tenderness and significant synovitis of most of her joints, her PIPs, MCPs, wrists, elbows, her shoulders. She's got effusions in her knees and ankles and MTPs. CBC demonstrates inflammation, otherwise the chem panel is unremarkable. She's got a positive ANA with a negative subserologies, highly elevated inflammatory markers, and then she has a high titer positive rheumatoid factor and anti-CCP. So this patient with chronic polyarticular inflammatory symmetric arthritis with high titer positive rheumatoid factor and anti-CCP has a diagnosis of seropositive rheumatoid arthritis. I've included this case because though this is a lower percentage, about 3.5% of FUO autoimmune cases are due to rheumatoid arthritis, RA is very common. About 1 in 100 of the population will have rheumatoid arthritis, and close to 6% will have fevers due to this disease. This is a clinical diagnosis. It's a chronic polyarticular symmetric inflammatory arthritis involving the small, medium, and large joints. It's often proliferative and destructive. And it is a systemic disease. So everyone has joint involvement, but also the lungs are fairly often involved, and this can be ILD, can get effusions and rheumatoid nodules. The eye can be involved. This is a demonstration of scleritis, which is one of the ophthalmologic manifestations. And then they can be systemically ill. So fevers, unintentional weight loss, night sweats, all can be a manifestation. Certainly patients with RA do get infections and malignancy, and so other entities need to be ruled out, but the diagnosis of exclusion can be due to the RA. Serologies are very helpful and do highly positive titers do predict more severe and potentially systemic disease, and that's about 80% of patients will have positive rheumatoid factor and or anti-CCP, but there is a percentage of patients who do not have positive serologies, but do have a clinical diagnosis. Our last patient is a 32-year-old female coming to urgent care due to swollen ankles, painful rash, and fevers. She's had fevers every day over the past 2 weeks, ranging from 101 to 102. She's having trouble working because she is a waitress and having trouble walking because of the ankle pain. And then over the last couple of days, she started to develop some painful lumps on her legs, and then now they're spreading to her arms. And so she is coming to the urgent care for evaluation. She's taking ibuprofen around the clock, which helps a little bit. On exam, she's mildly tachycardic. She appears uncomfortable but not non-toxic. The most notable findings are on her skin. She's got tender erythematous subcutaneous nodules on her legs, as circled here. She has a couple on her upper extremities as well. And then on musculoskeletal exam, she has warm, moderately sized effusions of both of her ankles with associated decreased range of motion. The data demonstrates signs of inflammation on her CBC, otherwise her chem panel is pretty unremarkable. She has elevated serum inflammatory markers. And due to the inflammatory arthritis involving both of her ankles and clinical suspicion for erythema nodosum causing the nodules on her lower extremities, a chest x-ray was obtained and demonstrates bilateral hilar adenopathy, as demonstrated here. This is a case of sarcoidosis. Sarcoid is considered to be about 2 to 6% of autoimmune FUO cases, and about a third of patients with sarcoid will have a fever at some point. This is considered the great mimicker within the rheumatology world. It can attack anything from the CNS to the prostate and everything in between. Most often, this is a biopsy diagnosis, which demonstrates non-caseating granulomas. In this case, this was a pretty classic case of Lofgren syndrome, which is the bilateral ankle inflammatory arthritis, erythema nodosum, and hilar adenopathy triad. And so biopsy was not done. And as she responded to the care that to the treatment that we prescribed, we did not need to do any tissue diagnosis. The ACE level really is not very helpful. So I recommend against checking it. I don't know what to do with it if it's positive or if it's negative because it does not rule in or rule out a diagnosis. All right, so just a few final thoughts. When I was preparing for this talk, I did a lot of reading and was surprised to see that there is quite a big difference in the rheumatologic causes of FUO in the Western versus non-Western populations. I'm not going to read these out, but I think it's important to consider, is this because of genetics? Is this because of exposures within the environment or different infections, toxins, lifestyle? I think there's a lot of unknown within the autoimmune world, and that I remain open-minded and humbled in evaluating in these cases. And just for fun, Dr. Richie Wernick was one of my mentors when I was a resident, and he was one of the smartest people I know, and he told me that Google is a valid tool to use when a diagnosis is unknown. And there were several times where we would together put 3 different symptoms into Google to see what they came up with in terms of the differential. Fast forwarding 15 years or so, I think that AI, which is mentioned at every single conference that I go to these days, is a valid tool for us to use when a diagnosis is unknown. I, for fun, entered the symptoms of our patient with Still's disease, and the AI tool came up with adult onset Still's disease as the first in the differential, and then included workup that should be done. I will say I think I still have a job because I did this for the Vexus patient, and Vexus was not on the differential. So I'm hopeful that you'll still consult me when there are tricky cases of a fever of unknown origin, both so we can be involved with the man, evaluation and the management as well. So in summary, when evaluating the fever of unknown origin, we need to first rule out infections and malignancy. An autoimmune diagnosis may be a diagnosis of exclusion, as we do not have a gold standard diagnosis in for many of the diseases that we see and treat. It is thought that the longer the duration of an undiagnosed fever, it makes this more likely to be a rheumatic etiology, and that we also need to look for uncommon presentations of common diseases, more so than the zebras, though those are fun to chase. We also always search for that objective information. So tissue is the issue, but I've been humbled here as well because even this is flawed. There can be sampling errors, there can be mishandling of the tissue. There are studies that show interpathologist discrepancies in diagnosis. So still, I think it's important to consider your pretest probability and then have discussions with our colleagues when trying to put our heads together about different diagnoses. This is also not a comprehensive list of all of the autoimmune cases of FUO. There are periodic fever syndromes, other autoinflammatory syndromes, other vasculitides. There are a bunch of others. So I just want you to know these are not the only diseases that cause an FUO from the rheumatology world. We also should consider disease prevalence. The patient demographics is important. The availability of the diagnostic techniques, and then our own diagnostic bias. And finally, again, I would say maintaining humility is a big part of my job these days. There are new diagnoses that are emerging, such as VEXA syndrome. Medicine is evolving with more and more excitement about the genome and the microbiome. And we have new exposures. We're living in a different world. So I think we will all have to stay tuned to see how the fever of unknown origin and its understanding and diagnosis evolves over the coming years as well. Those are my citations, and I thank you for your attention and welcome any questions.
Fantastic. Thank you so much, Dr. McCulley, for a framework and just a whirlwind of course, fascinating cases. So great. Let's see, questions popping in, starting with, can Behçet's present as an FUO?
Yes, yeah, Behçet's is one of the types of vasculitis which can present as FUO. Typically, there's also going to be the other manifestations like uveitis and skin cutaneous involvement, and then also the oral and the genital ulcers. But yes, that can be, before those manifestations come, the fever can come as well.
Great, thanks so much. Thanks for talking about PMR, certainly a common diagnosis that I agree we all see, and some of its intersection with giant cell arteritis. A couple questions in that realm. First off, in a patient with classic PMR, lacking other specific concerns for vasculitis, are we to go looking for vasculitis, for example, with CTA and those patients?
Yeah, great question. No, I would say in a patient with classic PMR, I would not go looking. That I would start with the prednisone and then the taper. I do with PMR patients screen clinically. So if they're saying, "Gosh, I have a new headache," or now I'm no longer, I ask about chewing gum or chewing chewy food for that jaw claudication clinical symptom. But no, if they're not having any symptoms, I would not go hunting with a CTA. That would be more in the patients with giant cell arteritis. That's a suspected diagnosis. Then we'd go looking for more extracranial involvement.
Great, thank you so much. And speaking of tissue being the issue, question in the diagnosis of GPA, can a skin biopsy ever be sufficient, or do you really need to go after like a kidney or lung or something?
Yeah, great question. No, I would say a skin biopsy that shows a small vessel vasculitis with classic pulmonary renal involvement and positive ANCA serologies. I think many of us would bypass, and this is probably a little bit stylistic, but many of us would just feel okay bypassing the kidney and the lung biopsy, knowing that gosh, if our clinical suspicion is high enough that those are quite risky. So yeah, I would say in that case, but typically we want the ANCAs to be positive. If they're not positive with that systemic involvement, then more likely we would want more of the organ biopsy.
Great, thanks so much. And in just the last minute, I think many of us, certainly I, learned about a new diagnosis of VEXAS, so thank you. Curious if the patient was ever treated empirically with prednisone sort of during the course of his treatment, and what treatment he ultimately really needed.
Yeah, great question. So, yes, he was treated with lots of prednisone, and then he would taper off the prednisone, and then everything would come back, or the fever would come back, and then there'd be another area of inflammation. I definitely did an abridged version patient presentation there, and that was probably, I think it was after the second hospitalization where it was determined this was probably not an infection, where we empirically treated him with 60 milligrams of prednisone as he had some organ involvement. And then ultimately he is on, so prednisone is the first line treatment, but he's actually transfusion dependent. And so we've been trying to get a JAK inhibitor approved, which is JAK inhibitors, and then IL-6 inhibitors have been the biologics that have shown the most promise, but there's still so much unknown. This is the saga continues. Maybe I'll update this in another 10 years if I talk again.
Fantastic. Well, we will look forward to having you back. Thank you so much, Dr. McCulley.
Of course. Thank you so much.